So hi everyone, my name's Ellie. I am an F2 and I've just finished my placement on Obs and Gynae. So today I'm going to be doing a talk to you about obstetric emergencies, but mainly focusing on antepartum and postpartum hemorrhage. They're the most common sort of emergencies that you might be asked about at med school or in OSCE, so focusing on those. Shall I wait for a few more people or shall I just start?
I think feel free to start, Dr. Baker. This seems like a good amount so far.
Okay, fab, thanks. Okay. So the first slide is just a quick disclaimer from me in becoming a doctor. So just to let you know that this lecture is just for your revision purposes, really. Not to replace any teaching that you have at uni and not for you to use as medical advice instead of seeing somebody if you need to yourself. So the learning objectives for this talk is mainly, like I said, looking at antepartum, postpartum hemorrhage. So understanding the definition, risk factors, causes, diagnosis and management of both. And then having a look at the main causes of both. So for antepartum hemorrhage, Placenta Praevia, Vasa Praevia and Placental Abruption. And then for postpartum hemorrhage, having a look at the 4 T's, so tone tissue trauma and thrombin. So starting with antepartum hemorrhage, these are just a few of the more common OSCE stations that you might be asked about with regards to antepartum hemorrhage. So the history taking stations. Things you might get is vaginal bleeding during pregnancy and a list of differential diagnoses, and the same for abdominal pain during pregnancy. And then you could get a reduced fetal movement station, history taking station. And then examination wise, mainly just speculum examination, which would obviously be in a model, but you might get some pictures of pathology and be asked to diagnose those, or a shocked patient, so more of an acute station. And after we've gone through antepartum hemorrhage, we'll come back to these stations and go through how you would sort of tackle each of those. So antepartum hemorrhage, the definition is bleeding from or into the genital tract from 24 weeks of pregnancy onwards until the birth of the baby. 24 weeks is sort of an arbitrary cutoff, but it's basically based on when the fetus is thought to be viable and have a chance of survival. So bleeding before 24 weeks has a different set of causes, and there's bleeding in early pregnancy, and we're not going to talk about that today. So antepartum hemorrhage is mainly split up into these 4 sort of ways of looking at severity. So spotting, which is just very light bleeding, minor hemorrhage, which is less than 50 mils and has now settled down, major, which is 50 to 1,000 mils, and no signs of shock, and massive, which is more than 1,000 mils or anything less than 1,000 mils if there's signs of clinical shock. It's important because it complicates about 3 to 5% of pregnancies, and worldwide it's the leading cause of perinatal and maternal morbidity, so it's really important we understand it. In the UK, it's a less common cause of death, but it's still in the top 5 causes of death related to pregnancy. And these are the main causes of antepartum hemorrhage. So we'll talk about all of these except for labour, really. So labour, bleeding at the beginning of labour is common, might represent the loss of the mucus plug or just some light spotting at the beginning of labour. But obviously that would be accompanied by contractions or rupture of membranes. And you might see the contractions on the CTG, and when doing speculum or a VE, then you should have signs of labour, so softening, effacement or dilatation of the cervix accompanied by that. So we're not going to really talk about that today, but it's obviously important to keep in mind that it could just be labour if it's a very small amount of bleeding. The other causes are the other main causes are Placenta Praevia, Vasa Praevia, Placental Abruption, lower genital tract bleeding, so vulva, vaginal, cervix, or unexplained bleeding, so bleeding that we cannot find a cause for, and that's actually quite common. So after we've talked about antepartum hemorrhage in general, we'll talk about each of these in turn. So with regards to antepartum hemorrhage, if this came up as a shocked patient in an OSCE or in real life, the thing you should always do first is an A to E assessment. So obviously a hemorrhage can be massive in pregnant women and therefore they can be shocked and high risk of mortality. So it's always important to start with an A to E assessment. The main things you're looking for for hemorrhagic shock would be tachycardia, hypotension, clamminess, cat breathe for more than 2 seconds, and then symptoms wise, maybe syncope, or she might be complaining of chest pain. And it's important to remember for antepartum hemorrhage that these symptoms might seem disproportionate to the volume of blood that you're seeing PV. So it's possible for the blood to be concealed, and so actually it's important to go off of the maternal signs and symptoms rather than what you're actually seeing in front of you when thinking about antepartum hemorrhage. Assuming the mum was stable, then you'd want to go on like you normally would to take a full history and do a full examination. So the main signs and symptoms you would want to talk about would obviously be the bleeding that she's experienced. So ideally you'd want to get an idea of how much this bleeding was. I think we all know that very often this is not accurate at all. So women have difficulty describing how much blood they've lost, but a lot of the time they will have put a pad on prior to coming to the hospital. So you might be able to ask them about loss into pads, how many pads they've had to use, or if it was real life, you could look at the pad yourself. You also want to know about the duration of this bleeding. So has it only just started or has this been going on for a long time? Did anything happen prior to the bleeding? So any abdominal trauma that might have caused it? And is this her first episode of vaginal bleeding in this pregnancy, or is this happening a lot? And therefore, does she already know the cause or know why this might be happening? The second thing, so anyone with vaginal bleeding, you want to ask them about abdominal pain. So you would do a normal pain history for anyone who did have abdominal pain, so Socrates history. You need to go through all of those things, but particularly focusing on abdominal trauma or any genital trauma that they might have had that might be the cause of this bleeding. And then you also always need to ask about fetal movements in any pregnancy history. So particularly be concerned if there is a reduction in fetal movements accompanied by the bleeding or the pain. After talking about her initial signs and symptoms, you'd want to go on to do a current obstetric history, a past obstetric history, and a medical history. So a lot of the time the patient's handheld notes are really good for this, but also you can obviously just ask the patient if it's on OSCE setting. So the things you want to know really is her gestation. So how many weeks is she? Parity, so is this first baby or has she had previous pregnancies and babies? Has she had any complications during this pregnancy herself? So preeclampsia, hypertension, any problems with the growth of the baby? Did she have any bleeding in the first trimester? Anything like that that might put her at a higher risk or give you a clue as to what's causing this bleeding. Then you want to go through previous pregnancies, particularly focusing on risk factors that might give you an idea as well. So did she have any antepartum hemorrhage in previous pregnancies? Did she have any postpartum hemorrhage? What gestation was she when she gave birth, and how did she give birth? So obviously women who had previous C-sections, that's going to give you a different idea of what might be going on than if she gave birth vaginally previously. And then you just want to go through your scans. So if this was real life, hopefully you would have the scans in front of you. In an OSCE, she might know the report. So the things you're mainly thinking about is the location of the placenta. So has she already been diagnosed with a low-lying placenta or Placenta Praevia? And the growth of the baby, whether this is a multiple pregnancy, so if it's twins, that might give you a different diagnosis. And also looking at the lycra around the baby and the blood flow to the baby. So most scans we do Dopplers, so that looks at the blood flow to the baby through the placenta. And it might give you an idea of any problems with the placenta that has happened previously that might point you towards a different diagnosis. Then you want to go through your initial examination. So after doing all the observations and everything like that, the first thing would be an abdominal palpation. So you could also get that station in an OSCE and palpation of the pregnant abdomen. You'd want to do this anyway, but the main thing you're looking for here is abdominal tenderness. So if you've got any tenderness anywhere, can you feel the uterus? Does the uterus feel hard and tense, or is it nice and soft? Can you feel any contractions as they're happening? A lot of the time, if a woman's having contractions when you palpate, you can actually feel them. Then you also want to do your normal assessment, so measuring of the fundus, to the symphysis pubis to see the growth of the baby, the presentation of the baby, so is it breech or head down, and sometimes you can feel fetal movements, which will obviously be reassuring for you. Followed by that, you'd probably want to do a speculum examination. So a lot of the time, people often say if you know someone's got placenta previa, not to do a speculum, but actually speculum examination is quite safe, even if you know she's got placenta previa, as it doesn't actually cause trauma to or touch the cervix when you do a speculum. The main reason for doing a speculum is really to look at the lower genital tract, so you're able to obviously see the vagina, the vulva, and the cervix when you do a speculum. So when you do it, you might see a cervical abnormality or an ectropion, or in the case of labour, you might see the cervix actually dilated, and you might see the baby's head. And then a vaginal examination, so that's a digital vaginal examination. So this is the examination that you shouldn't perform if there is a risk of placenta previa. So if she's had a scan and you already know she's got placenta previa, or you don't know where the placenta is, for example, she hasn't had a scan or she hasn't got scans with her and she's got bleeding which is painless, then she's obviously at risk of having placenta previa, so you shouldn't do a vaginal examination with your digitally. But if you know the placenta is far away from the cervix from previous scans, and you think the patient might be in labour, then you can do a vaginal examination, and this allows you to feel for cervical dilatation and texture as well. And then the last part of your assessment would be a fetal assessment. So initially that's just fetal heart auscultation, usually with a sonocaine, so the Doppler listening to the heart. If you can't find the heart, then you'd want to use a proper ultrasound scan to visually assess for the fetal heart and make sure there's not been any intrauterine death. And then you can also do a CTG, so to assess the fetal heart and have a look at, and this gives you a lot more information about fetal well-being. So that would be your assessment of a woman coming to you with vaginal bleeding, as long as your A to E assessment was fine and she was stable. So then to move on to emergency management. So this would be if you were doing your A to E assessment and she was unstable in any way, so any of those signs of major hemorrhage, then obviously you wouldn't continue with your long history. You would find the problems and fix them as you go along. So with regards to A and B, usually there won't be a problem, but it's important to remember that if she has had a major hemorrhage, then she might have a low DCS and therefore her airway actually might be unsafe. So you always need to assess that anyway. And most of the time we just put on 15 litres via non-rebreathe, regardless in anyone who's in shock. C is obviously the most important one. So the same as any normal major hemorrhage, really. You need large bore IV access, and you need to take bloods for FBC, clotting, fibrinogen, and you also need to cross-match some blood as well. The things that is important specifically to remember in pregnancy is, like I said before, there's the possibility of concealed hemorrhage. So just because there's none or barely any bleeding from the vagina doesn't mean there's not bleeding going on inside. So you need to base your assessment off the clinical signs and symptoms rather than what you can physically see. And it's also important to remember that in pregnancy there's an increased blood volume. So she might not actually show any signs or symptoms of hemorrhage until she's lost nearly a litre of blood. So it's quite important to remember that as well. Then it would just be, so you would have your massive obstetric hemorrhage call. So this is something that you can put out in most hospitals like a cardiac arrest, so 2222, and you put out this call. And that alerts everyone that needs to know, so your obstetricians, anaesthetists, also the haematologist, of what's going on, and the blood bank. And that will allow you to receive major hemorrhage packs, which have specified amounts of red blood cells, FFP, cryo, platelets, things that you might need. And these will change as you go along, depending on the blood results and mainly the advice from the haematologist. The other thing to remember in pregnancy is the left lateral tilt. So with the picture here, you can see in pregnant women, specifically later gestations, the baby is actually quite big and there's quite a lot of amniotic fluid. So that can actually compress the IVC, and that can reduce venous return to the heart and actually make the situation much worse. So by asking her or getting her to lie onto the left-hand side, as you can see from the picture, that allows the pressure to come off the IVC and increases venous return. If she's GCS3, then the baby in the abdomen can just be pushed by a member of staff to the left-hand side, and that does the same thing. So that's C pretty much covered. So D and E is the same as normal, really. GCS, glucose, and looking for any other causes or signs of bleeding, and maintaining body temperature. And then the F part of this is the same as before, so your fetal assessment. So in these situations, it's always maternal well-being, which takes priority. However, obviously, ideally, you also want to assess that the fetus, how the fetal well-being, and you need to be thinking about whether you need to get the baby out, both for maternal and fetal well-being, really. So at the bottom there, just put delivery. So in most cases, if you require this AT approach and resuscitation, then you're going to want to deliver the baby. So any form of massive hemorrhage can obviously be life-threatening for both the mum and the baby. If you deliver the baby, you're also delivering the placenta, which is usually the cause of bleeding in these situations, and therefore you're actually removing the cause, and hopefully that will help with your resuscitation. So this normally needs to be done via an emergency C-section. So that's the emergency management of APH. So then we just move on to the non-emergency management. So these would just be things to consider if there was no evidence of maternal or fetal compromise at all. So the first one's a Kleihauer test. So that's just the test that you would need to do for any woman who was rhesus negative. It's just a normal blood test that you can take from mum, and it gives you a measurement of the amount of fetal hemoglobin in the maternal bloodstream. And then this will allow you to calculate the dose of anti-D that mum needs. And all rhesus negative women need anti-D if they have an antepartum hemorrhage, regardless of what the cause is. The second thing you want to consider is an ultrasound scan. So if you don't already know the placental location, then obviously this is something that you need to find out, and this is best done with an ultrasound scan. The scan also obviously gives you an idea of fetal well-being, and sometimes you can see a retroplacental clot on the scan, so a clot sitting between the placenta and the uterine wall, and that suggests that there's been some type of abruption. It might have been a small abruption and not big enough to cause any compromise, but it lets you know that that's what's happened. But a lot of the time, well, 70% of the time, abruptions are missed on ultrasound scans, so it's not actually a diagnostic tool for abruption, but it can be helpful. Then you need to think about whether this lady needs to be admitted to hospital. So if she's just had very light spotting and it's completely settled, and you know from previous scans that she's not got Placenta Praevia, then the likelihood is she can go home, and then you would just give safety netting advice to come back if the bleeding continued. If you already know that she's got Placenta Praevia, then even if it's just spotting or a very small amount of blood, then the advice would usually be for admission to hospital for at least 24 hours, because these women are at quite a high risk of recurrent bleeding, which could obviously be much heavier. But this needs to be discussed with the women and her opinions as well. If it was more than spotting, so a minor bleed, say 100 mils, no matter what the cause is, or even if you can't find a cause, then again, the advice would be for admission for at least 24 hours. And any ongoing bleeding, then the advice would be for admission at least until the bleeding had settled down. Corticosteroids, so you would have a think about this, just because corticosteroids help with respiratory distress syndrome, mortality in the infant, and they also help with intraventricular hemorrhage in the infant if it's at high risk of being born prematurely. So anyone who has bleeding, who you feel like is at high risk of preterm labour and is between 24 weeks and 35 weeks, then you would have a think about whether you would give mum some steroids to help with baby's lungs. But it's not just something that you would always give, because it's actually most helpful when giving in the days before delivery. So if you give it 24 weeks and baby's born at 35 weeks, it's actually not very helpful for the baby. So you have to be a bit sparing with who you give them to and who you don't. Obviously, this would be a consultant decision, not one of us. And then thoughts about timing of delivery. So if there's no compromise for mum or baby, then you can actually think about when it's safest for delivery. If there's been a lot of bleeding, so a major or massive bleed, and the gestation is more than 37 weeks, then you would probably just deliver, because the risk to baby is quite small as they're at term. If it's less than 37 weeks gestation, and both mum and baby are stable, then you would probably admit them to hospital for observation, and discuss whether they need to be delivered during that admission or at what time they would need to be most safely delivered. And then the last one, just changing antenatal care. So if they've had an APH, more than spotting, if you don't know the cause, or if they have Placenta Praevia, or they've had a smaller placental abruption, then they need to be a high-risk pregnancy from now on. And that means that their antenatal care needs to be led by a consultant, and they need serial ultrasound scans to assess the baby's growth and the fluid around baby and the blood flow to baby with doctors. So this is just covering the complications of APH. So obviously complications for both mum and baby, there is a risk of death. So that's the most significant that we need to think about. For mum, any person who has an APH is then at higher risk of having a PPH. That needs to be thought about when she goes into labour or if she has a C-section. Obviously, if there's significant enough blood loss, then she's at risk of anemia, and you need to prevent and treat that. There's also an increased risk of genital infection. If she's had to have a blood transfusion, there's obviously all the complications associated with that. And then if she's admitted to hospital, then complications associated with that, the most significant being VTE, as pregnant women are at high risk anyway, and then hospital admission adds to that risk. For the baby, obviously, there are other risks of being born prematurely, either iatrogenically or spontaneously. Having some form of hypoxic injury because of blood loss, so mainly we worry about hypoxic brain injury. There's also a risk of the baby becoming anemic, and then needing blood transfusion post-delivery. Reduced growth, so that's obviously if there's a problem with the placenta, then the rest of the pregnancy might be affected. And a premature rupture of membranes is also a risk, which would leave the baby at higher risk of infection, because there's no membranes left there if the decision wasn't for delivery. So now we'll just go over the causes of APH and the most significant ones that you'll probably be asked about or come across. So the first one's Placenta Praevia. There's a lot of different definitions of Placenta Praevia, but the one that Royal College of Obstetrics and Gynaecology are using now is Placenta Praevia is when the placenta lies directly over the internal cervical os. And a low-lying placenta is the term used when the placental edge is within 2 centimetres of the internal cervical os after 16 weeks of gestation. So if you're on labour ward or whatever, you might hear other definitions such as Placenta Praevia minor and major. So minor would just be the placental edges inside the lower uterine segment or reaching the cervical os, and major would be partially or fully covering the cervical os. So you might hear those as well. And Placenta Praevia is actually quite common, so it occurs in about 1 in 200 pregnancies, so it's something always to think about. The main risk factors for it are obviously previous C-section, and the risk of placenta previa increases with the number of C-sections that you've had. Any other reason for the endometrium to be deficient, so if they've previously had a termination of pregnancy or a manual removal of placenta, which might cause damage to the endometrium, they're at higher risk. The same with the submucosal fibroids, so fibroids sticking into the uterine cavity, that increases risk of placenta previa. And then other things such as advanced maternal age, twin pregnancy, smoking, they all increase the risk of placenta previa. Most of the time, women who have placenta previa will either be asymptomatic and it will be diagnosed on a scan, or they will have painless vaginal bleeding. And like we said, this can either be a very small amount or it can be a very, very large amount. It usually is diagnosed on the routine 20-week scan, so the anomaly scan. They always screen for placental location, so they should be able to see a placenta previa. If they're asymptomatic or they have a low-lying placenta, then they'll be rescanned at 32 weeks and then again at 36 weeks. And this is to talk about delivery and how the baby needs to be delivered. So a lot of the time, in 90% of cases of people with low-lying placenta, the placenta actually moves as the gestation increases and the uterus stretches. So it might be that the placenta is then far away from the internal os by 36 weeks and they can have normal delivery. Things we're always thinking about is vaginal examination and sexual intercourse. So you should advise the women that she should avoid sexual intercourse and you shouldn't be performing vaginal examinations on these women when they come in. And then our management really. So the first one is just looking at antenatal anemia. So you need to supplement with iron if antenatally mum's becoming anemic, because she's obviously going to be more likely to have problems if she then loses blood during delivery. Most women can be managed at home throughout their pregnancy. So particularly if they're asymptomatic or they've only had a very small amount of bleeding, it's most of the time they're likely to be able to be at home with a lot of safety netting advice of when to come in. But you do need to take into account the risk factors. So if they've come in multiple times with bleeding or they've had a large hemorrhage which needed transfusion previously, then obviously they might need to be admitted to hospital for the remainder of their pregnancy. And then with regards to delivery, so delivery for placenta previa needs to be via C-section. So Royal College suggests that this is considered between 34 weeks and 37 weeks because this is trying to balancing the risk between the woman going into spontaneous labour herself and the baby being immature and having a low chance of survival. So after the 36 weeks, the risk of hemorrhages increases. So they suggest between 34 and 37 weeks. If it's just a low-lying placenta, then sometimes some consultants may say that she can give birth vaginally if she's been completely stable, has no other risk factors, and if the fetal head is already past the edge of the placenta, so the placenta is not going to be in the way during delivery, then they may be able to give birth vaginally. And this picture here just shows you the difference between low-lying placenta and placenta previa. So the next thing is Vasa Praevia. So Vasa Praevia is when it's not the placenta or anything to do with mum that's in the way, it's actually the fetal blood vessels that are in the way. So it's defined as when fetal vessels run through the amniotic membranes within 2 centimetres of the internal cervical os. So there's the two types here. So type 1 is the picture on the left. So that's when the fetal vessels are connected to the placenta. It's called a velamentous umbilical cord. So basically what it means is the umbilical cord doesn't attach directly into the placenta itself. It splits up into the fetal vessels which aren't protected by something called Wharton's jelly. Those fetal vessels run through the amniotic membranes and then they attach into the placenta. And then the second type 2, is when the fetal vessels are connected to the placenta via an accessory lobe, or you've got a bilobed placenta. So that's the picture on the right. So the umbilical cord might attach directly into one lobe of the placenta, but then the 2 lobes of the placenta are joined via fetal vessels which run through the amniotic membranes. So in either of these cases, the fetal vessels are at high risk of rupturing when the membranes rupture. So either spontaneously or if the woman's being induced and we artificially rupture the membranes, they're at high risk of bleeding because they're not protected by that Wharton's jelly that usually protects the umbilical cord. The bleeding that would then occur would be from the baby and from the placenta. And so basically the effect mainly is on the baby, and the baby can actually bleed very heavily, very quickly. So this has high risk of fetal mortality. Fortunately, it's more rare, so only 1 in 1,200 to 1 in 5,000 pregnancies are actually affected by Vasa Praevia. Either they'll be asymptomatic and it won't be diagnosed, or they might have some painless vaginal bleeding. But in that case, you wouldn't really necessarily know it as Vasa Praevia because it could also be many other things, including Placenta Praevia. So the diagnosis is either antenatally, so sometimes on the anomaly scan or on later pregnancy scans, you can see a Vasa Praevia if the sonographer is experienced. If they use Doppler, it's more obvious, but it's not something that's specifically screened for, so it can be missed. So in the case that it's missed, then it's more likely to be diagnosed in labour. So this might be by the obstetrician or the midwife doing a VE. So sometimes you can feel the actual fetal vessels pulsating inside the internal cervical os, and obviously that would suggest that a Vasa Praevia might be present. Unfortunately, it's also sometimes diagnosed when the membranes rupture and there's painless vaginal bleeding, or the baby is acutely compromised on the CTG. So if this is an undiagnosed Vasa Praevia, then this would be an emergency cesarean section because there's a high fetal mortality rate, so up to 60% of the baby dying just through the loss of blood. If we've been able to diagnose it antenatally, then it needs to be delivered via C-section, and this is usually planned between 34 and 36 weeks as well. Because of the high risk of the baby being compromised very quickly, these women might be admitted to the hospital from as early as 30 weeks in their pregnancy and have to be in hospital for 4 to 6 weeks before they get delivered. So the next main cause to think about is placental abruption. So placental abruption occurs when the placenta partially or totally separates from the uterine wall before the baby is delivered. This occurs in up to 1% of pregnancies. Has quite a lot of risk factors, but the main ones to think about is if this has happened before, if she's got preeclampsia or hypertension, then she's at increased risk. If there's polyhydramnios, so if there's more fluid surrounding the baby, then they're at higher risk, because when those membranes rupture, the uterus contracts very quickly, and that puts them at higher risk of placental abruption. And if there's been any bleeding early on in the pregnancy, so before 24 weeks, then this is a high risk because it's thought that that bleeding might have come from between the placenta and the uterine wall, so a small abruption earlier on, and this puts them at higher risk later on. So the main signs and symptoms is vaginal bleeding with abdominal pain. So as we said before, this can either be revealed, so the picture on the left, that's where the placental abruption has occurred at the edge of the placenta, and so the blood's able to escape PV, or it can be partially revealed, so some blood comes out but some stays inside, or completely concealed, so the abruption happens sort of towards the middle of the placenta, the blood can't escape, you end up forming a big retroplacental clot, and you might get signs and symptoms of hemorrhagic shock but no actual PV bleeding. In placental abruption, there's also abdominal pain. It's usually quite significant pain, and it's continuous pain, unlike contraction pain, which is usually intermittent. And on examination, it's usually a tense, hard uterus. Some describe it as a woody uterus that you can feel in comparison to things like Placenta Praevia, where the uterus is soft. And because of the fetal compromise, you might get reduced fetal movement. Unfortunately, overall, there's no specific test which can be done to diagnose a placental abruption. It has to be a clinical diagnosis. And the management really depends on whether mum and baby are okay. So if it's a small placental abruption, this can be diagnosed on an ultrasound, like we said before, but it's not a very sensitive test. But you would then have to do a risk versus benefit of whether it's safer to deliver the baby or not, and that would just depend on the fetal and maternal well-being. If if there is compromise in either, then it's likely to be an emergency C-section. And if this lady isn't delivered, so she doesn't have a C-section, then she's at much higher risk for PPH, so that needs to be remembered when she finally is delivered. Then we have lower tract bleeding. So this is from the vagina, the vulva, or the cervix. From the vagina or vulva, there's not actually that many causes. Usually trauma is the cause. For example, sexual intercourse can cause trauma, which can cause a small amount of bleeding. It's more likely to be a cervical cause, so a polyp, like a benign growth that is coming from the cervix, can protrude and cause bleeding. An ectropion is when the sort of columnar cells from inside the cervical canal become present on the outside of the cervical canal. That's usually metaplasia from the normal squamous cells that are there transforming into columnar cells. And these columnar cells are more fragile and they just bleed more easily. So that's why these women are more likely to have bleeding. And unfortunately, this happens more in the presence of estrogen. So it's more common in pregnancy and it's more common if women are taking a combined. You could also have an abnormality or a tumour, so you need to ask a woman about a smear history. If she's previously had an abnormal smear or she hasn't had a smear for a long time, this might be more likely. And the last one is cervicitis, so an infection, maybe a sexually transmitted infection causing inflammation of the cervix. They're also likely to have change in their discharge, but they can also have bleeding. And then the last cause to look at is unexplained, and actually this is really quite common, that women have small bleeds during pregnancy and we're never able to find a cause. If this is recurrent, then it's really important that if it's recurrent, it's really important that you rule out all of the things we've talked about before, but it's also good to have a look at whether this is actually PV bleeding, as sometimes it could be PR or hematuria, and there's obviously lots of other causes for that. But even if we never find a cause for APH, these women still have increased risk of fetal growth restriction, preterm delivery and stillbirth. So it's really important that we recognise and are serious about these women who come in with explained APH. So there's just a question that is cervical ectropion associated with malignancy, and the answer is no. So ectropion is actually very, very common. It can be upsetting for women because it has the same symptoms as a malignancy, such as postcoital bleeding, but it's not actually a direct risk factor for a cervical malignancy. The main risk factor for that is HPV. Okay. Sorry, so if we just come back to the OSCE stations that we talked about at the beginning. So I think we've gone through vaginal bleeding quite a lot. The main things you'd want to talk about is the volume, the duration, any precipitating factors, if this is the first episode or recurrent, any vaginal bleeding before pregnancy, so like we were saying, cervical abnormality that might have been present before, change in vaginal discharge or vaginal loss, like the rupture of the membranes, that would suggest labour. Asking about abdominal pain, so your Socrates history, fetal movement, and then doing your full obstetric and gynaecological history, specifically, and then going through your past medical history, drug history, etc. When you do that, you need to ask about antiplatelets and anticoagulants, and you also need to check the rhesus status of the women to make sure she's not rhesus D negative, because if she is, she'll need anti-D. Your main differentials would be Placenta Praevia, Vasa Praevia, abruption, lower genital tract, or labour. Abdominal pain is basically the same, but in reverse. So you do Socrates and then ask about all those other associated symptoms. And your differentials are going to be similar, but focusing mainly on abruption. Labour could just be Braxton Hicks pain, could be uterine rupture, which is more common if she's had a previous C-section. Could be preeclampsia, so preeclampsia is usually associated with epigastric pain, and they might have other symptoms like nausea, vomiting, visual disturbance or headache. But it's also important to remember that pregnant women can have other things as well, so she could well have a gallstone. Any other cause of abdominal pain is possible in a woman who's pregnant, so you need to ask about other things as well. And then reduced fetal movement You mainly need to ask what's the normal pattern of movements for the baby, and how has this changed? How long has this been going on for? Is this the first time, or has this happened multiple times during this pregnancy? And do they have any of the previous associated symptoms that we asked about? And then you need to make sure that you do your fetal assessment, so an auscultation of the heart and a CTG. With spectral examination, obviously I can't really talk through that now, but I'm sure you've been taught, or you will be taught, spectral examination on a model. The main pictures you'll be shown are similar to the ones that I've got for lower genital tract bleeding, but they're most likely to be actual real life pictures. So it's a good idea to have a look at some of those. I just didn't feel I could put those onto the presentation, but it's good to have a look at pictures like that before you do the exam. And then we'll go through shocked patient a bit more when we talk about PPH, because it's more common to come up in PPH. So now we're just going to do some questions. So there'll be polls coming up. So if you want to just take a minute to read through the question, and then I'll start the poll and you can answer via the poll. So the poll should be up now, so feel free to answer. Okay, so quite a lot of you are voting. I might have to end it because I feel like we might run out of time. So if anyone wants to vote quickly. Okay, so I'll just end the poll now. So I can share the results with you. So most of you went for labour. So the correct answer is labour. So the reason why that it's labour is, from this question it says what is the most likely diagnosis. So other of these could be the diagnosis, but it talks about intermittent abdominal pain, which suggests contractions, only vaginal spotting, which is quite common, and also she's got no concerns regarding the baby's movement. She's completely stable. So Placenta Praevia is more unlikely because we've said she's had a normal pregnancy so far. This is her first episode of bleeding, and both her and the baby are stable, and she's got abdominal pain, which isn't common in Placenta Praevia. Placental abruption is less likely because this is an intermittent and moderate pain, whereas placental abruption is usually more of a constant severe pain. Also, she said the baby's moving fine and she's stable, so it's less likely. She could have a cervical ectropion, but it doesn't really fit with the history of abdominal pain. And she could have unexplained bleeding, but again, abdominal pain doesn't really fit. So neither of those two are the most likely diagnoses. So the second question, if you all want to take a minute to read the question, and then I will start the poll and let you all vote. Okay, again, I might have to just end the poll for time reasons. So if you want to vote, vote quickly. Okay, fine. So I'll share the results with you. So again, most of you went for Vasa Praevia. which is the correct answer. So we'd say Vasa Praevia is most likely diagnosis because one, she's being induced, she's had a, so it would suggest that she might have had a rupture of the artificial rupture of the membranes. She's had a normal pregnancy so far, so again that suggests less likely to be Placenta Praevia. Again, she's got heavy vaginal bleeding, which seems to mainly be affecting the baby, so that CTG is abnormal. She's got no pain and she's fine. So with Placenta Praevia, it's more likely we would have picked it up earlier, and it's more likely that we would expect maternal observations to be abnormal as well. If it was abruption, we would expect her to have some abdominal pain. If it was labour, again, we'd expect her to have some abdominal pain. We don't usually expect the vaginal bleeding to be very heavy, and we also don't expect the CTG to become suddenly abnormal. And then the last one, again, it doesn't usually cause severely abnormal CTG or heavy vaginal bleeding. So then if we move on to postpartum hemorrhage, so again, looking at some OSCE Stations, again, it might be PV bleeding post-delivery, looking at your patient in shock, and then talking through your emergency management of PPH. So I'm going to go a bit quicker, so I'll rush through it and then I'll answer your questions at the end. So PPH is more than 500 mils post-vaginal delivery or more than a litre post-C-section, or if there's any signs of hemodynamic shock. You've got minor and major, so minor is 500 to 1,000, post-PV, no signs of shock, and then major is 1 to 1.5, split up into moderate and severe. Primary PPH is within the first 24 hours after delivery, and secondary PPH actually occurs from 24 hours all the way up to 12 weeks of birth, so both of those count as PPH. These are 4 things you need to think about with PPH, so tone, trauma, tissue, and thrombin, the 4 Ts. Tone is by far the most common, so because of that, in the UK, we advise that we give prophylactic uterotonics routinely for active management of 3rd stage. So we give either oxytocin or symptometrin to help with detachment of the placenta from contraction of the uterus after the baby's born. Trauma can either be iatrogenic or spontaneous tear. Tissue usually refers to a retained placenta, and then thrombin is usually something related to the mum prior to this, so a coagulation disorder, being anticoagulated, or it can be increased in preeclampsia or eclampsia. These are the main risk factors, and these are one of the 4 Ts that they're associated with. I won't go through all of those, you'll get these slides afterwards, so you'll be able to have a bit of a better look. So it's the same thing as APH really. So with your emergency management, you need to think about your A to E approach and your massive obstetric hemorrhage call. The same with assessing A and B, it's mainly about GCS and whether she can maintain her airway. With C, again, about getting IV access, taking blood and replacing blood as needed with the massive obstetric hemorrhage packs. It's also really important in PPH to put in a urinary catheter, so this gives you fluid balance, but also if the bladder is full of urine, it makes it more difficult for the uterus to contract, and that's one of the first things that's always done if there's not a catheter there already, just to put one in. And then D and E the same as you usually would for any massive obstetric hemorrhage. So the most common cause, like we said, of PPH is atony. So a lot of the time, treatment for atony will be started as it doesn't cause any harm and it's the most common thing. But at the same time, you need to be assessing for other causes. So assessment for tone is usually just abdominal examination. You can often feel the uterus is quite boggy or not very well contracted. Also, you should be assessing for trauma, so doing a PV exam and a PR exam. Assessing for tissue, so you should, once the placenta has been removed, you should make sure it's complete. And then you will have already sent off your bloods for emergency management, so that's your assessment of your thrombin, really. So the medical management usually starts with management for tone, unless there's a really obvious other diagnosis. So that starts with fundal massage, so that's just putting your hand, finding the fundus by the abdomen and slowly massaging it down to see if you can get it to contract. Your second thing would then be bimanual compression, which is what the picture shows. So while you do this, you would insert one hand PV. You would try and expel any clots from the vagina or the uterus that you could feel, as these can often inhibit uterine tone as well. And you would put that one fist into the anterior fornix of the vagina, as you can see on the picture, and then your other hand goes on the mum's tummy, and you try and basically compress the uterus between your two hands. And once you've done that, you basically need to hold it there with pressure until the bleeding stops, or until you've moved on to another type of management which requires you to remove your hands. And then you would start medical management. So your first things that you're going to start with are oxytocin and ergometrin. So these are, oxytocin's an endogenous hormone that we have anyway. It is released post-birth, and it stimulates rhythmic contractions of the uterus. So we can give that IM or IV. And then ergometrin is another drug. It's a prostaglandin which helps contraction of the uterus, which you can also give. You would usually give some stat doses, and then you'd follow it up with an oxytocin infusion to try and help. There's also misoprostol, which is another prostaglandin. It's usually given PR to help, or it can be given sublingually, but it doesn't usually work that quickly. It can take up to 30 minutes to 120 minutes to work. So it's more of a prevention later on rather than treating it right this second. There's also something called carboprost, which is another prostaglandin. You can give IM, and you can also give directly into the uterus if you're having a PPH during a C-section. And then you also think about tranexamic acid. So obviously, to try and reduce the volume of bleeding, tranexamic acid is something we use in all types of major hemorrhage. So that would be your sort of initial medical management of a PPH. And obviously a lot of that focuses on tone. So if there was a really obvious other cause, such as a massive trauma, then you might not do all of these things if you felt that the uterus was well contracted. So then moving on to tone. So basically, tone is a clinical diagnosis, like we said, examination of the abdomen. If the uterus doesn't contract well, then all those vessels are still left bleeding, and that's why it causes PPH. So again, you would start with all that medical management that we just went through in the last slide, but then if none of that worked and she was still bleeding, then your first line surgical management would be an intrauterine balloon tamponade. So that's this on the left. It's basically kind of like a catheter. You insert it into the vagina and through the cervix, and then you inflate the balloon at the top with saline or water. It's usually a few hundred mils, up to 500 mils that goes into that balloon. This little bit at the top here is an open tube which comes out here, which you would then attach to like a normal urinary catheter bag, and that will drain the blood, so you can see how much blood is draining. So basically you can see if your tamponade is working or not. If lots of blood continues to drain out of there, you would obviously need to move on to your next thing. But if it worked, then it's usually vaginal plaques are placed down here in the vagina to keep it in place, and then it would gradually be deflated after about 12 to 24 hours. If this doesn't work and you've still got a lot of bleeding coming out the end, then you might go for brace sutures if you're already in a C-section. If you're not, you've obviously got to make the decision of whether you're going to open the abdomen or not. So brace sutures are basically simple stitches that go through to the other side of the uterus, up and over and round on both sides, and they're pulled really tightly, and that's basically just a mechanical external contraction of the uterus to try and stop the bleeding. If that didn't work, you might call in vascular surgeons or IR, and they might either ligate or embolize the arteries. So you'd usually start with the uterine arteries, one side and then both sides. And basically you would get more and more higher up ligation or embolization to see if you can stop the bleeding. And then your last resort is usually a hysterectomy, an emergency hysterectomy. And that's if everything else has failed. You usually need 2 consultants there to decide if this is the right idea. But Royal College do say if the bleeding is very, very significant, you should consider this early, because it's usually obviously going to stop the bleeding. But you've got to think of the effects that this is going to have on the woman and her future chances of pregnancy. So just a question. So the brace sutures, so there's not actually any evidence that it does have future impact on fertility. you would need to remove the sutures. Obviously, it would mean that she couldn't have another baby if they were contracted this tight, because they're usually sutures and not ones that will dissolve or anything like that. But that would depend on, usually you're able to remove them if the bleeding has completely stopped and you're slightly contracted. They might be left in for some time and then removed later. It's going to completely depend on whether they're still bleeding and whether it works or not. So moving on to trauma, this is the second most common cause of PPH. So up to 85% of women will have some form of perineal trauma, and 60 to 70% of those will need suturing. So the way you assess trauma is basically doing a PV examination and a PR examination. So that's to see where the trauma is inside the vagina and if it's gone through to the rectum or anus. But you also need to consider that there could be tears higher up in the vagina or of the cervix itself, particularly if you've done like a forceps delivery. This can tear those, and these would need to be sutured as well. You can also have a uterine rupture, so higher risk in people who've had a previous C-section. They usually get quite severe pain in their abdomen over the scar site. It can occur when they're pregnant, as the uterus stretches, but it's more common in labour, but it is actually overall quite rare. So these are the classifications of tears. So first degree is just to the skin or the vaginal mucosa, and usually these are just left alone. Second to fourth degree and episiotomies are all usually sutured. We suture them to help with the bleeding, helps with healing, reduces risk of infection. It also helps the function of the muscles. It's usually either done in the room if it's a grade 2 or in theatre for grades 3 or 4, and grades 3 and 4 also require antibiotic cover as they've been exposed to the rectal mucosa. So then second degree is to the perineum and the muscles, but doesn't involve the anal sphincter at all. Third degree has these three classifications, A, B, and C, and they basically involve either the external percentage of the external sphincter or both the external and internal sphincters. And then fourth degree is going all the way through to the anorectal mucosa. And then an episiotomy is when we do a surgical incision of the perineum, and this is basically to increase the diameter of the vulva. And we do this if the perineum is very stiff and the baby's not coming, if we need to do an instrumental delivery, if there's a breech delivery, or if the baby's getting distressed and we need to deliver more quickly, or if there's a shoulder dystocia, these will all be done. And an episiotomy would always need to be sutured. And then for aftercare, they need to avoid constipation, and then they would have pelvic physio, especially if it's a grade 3 or 4, and then grade 3 and 4s would be followed up in the pelvic floor clinic for assessment of their function and to give them advice on how they need to deliver next time. If it's a 4th degree TE, they might be suggested to have a C-section next pregnancy. For tissue, so tissue usually refers to retained placenta. So it's called retained if it's not been delivered within 30 minutes, if we're actively managing, or 1 hour if we're not actively managing. So this can be a number of different things. Either if the uterus and the cervix contracts very quickly, the placenta can kind of get trapped inside. If you just pull controlled cord traction on the cord, this might help and deliver the placenta. You can either then have some mild adherence of the placenta, which is arguably on the placenta accreta spectrum, or you can have just a piece of the placenta broke off and is left inside. So that's why you need to assess the placenta once it's come out and make sure it's complete. And then if there is a piece of placenta left inside, you might have to do a manual removal of placenta, and that literally involves going to theatre and manually using the ultrasound to assess where the placenta is and manually removing it via the cervix. And then there's placenta accreta. So placenta accreta is sort of a spectrum of disorders, and it's where the placenta is abnormally adherent to the uterine wall. So there's this full spectrum. So accreta is adherence to the myometrium, which is this picture. Increta is where it's come through into the myometrium. There's deeper invasion, and it can be down to the serosa here. And then percreta is through the serosa, and it can go into other pelvic organs, most likely the bladder. This is higher risk if she's had a C-section or other surgery to her uterus. And if you've got a low-lying placenta at ultrasound scan and a previous C-section, then you should always be thinking about placenta accreta spectrum. It can be diagnosed on an ultrasound if you have an experienced sonographer who can do it, or it can be diagnosed with MRI, and that allows you to see how deeply the placenta invades into the myometrium. All these people should be managed in a specialist tertiary centre. They need planned delivery between 35 and 37 weeks, again for balance between risk of them going into labour on their own and the baby being immature and having a lower chance of survival. The management is basically based on once you get in. So they have a C-section. Once inside, if the surgeon feels that they might be able to do a partial myometrial section, so remove the placenta and remove part of the myometrium, they might be able to do this. But if it's felt that trying to get the placenta away is too risky, then they would mostly advise just doing a hysterectomy with the placenta still in situ. Obviously, some women might find this unacceptable if they still want more children. So there is the possibility of leaving the placenta inside. And the aim of this would be that the placenta would be spontaneously resorbed by the body. But this is quite high risk. So they can still hemorrhage. They can still they're at high risk of infection. They can form a fistula. So there's quite a lot of risk behind doing that, but it's something that might be discussed if the women really felt strongly about not having a hysterectomy, which obviously quite a lot of women might do. And then the last one's thrombin. There's not that much to say there. So preeclampsia and HELLP syndrome, the mechanism's not clear, but it's thought that maybe high blood pressure and the blood vessels don't constrict properly. And then in things like HELLP, you've obviously got thrombocytopenia, deranged liver function, which might affect your clotting. Sepsis, for example, you can get DIC, that's going to make you more likely to bleed. Past medical history, so any clotting disorders the mum has, or if she's anticoagulating for any other reason, she's obviously at high risk. And then just quickly, secondary, so between 24 hours and 12 weeks of birth, it's going to have some slightly different causes. You could still have the 40s, so tone, if it's like just after 24 hours, could happen. Retained placenta is the most likely from that, which you can do an ultrasound to assess if they've got any retained placental tissue. Trauma, you can still have bleeding from sutures or from a trauma site, but the most common one is endometritis, so infection of the endometrium, which can cause bleeding. So you would need to do some swabs and give her some. So these are our OSCE stations that we talked about before. So if it's a history, it's most likely to be a secondary PPH because primary PPH would be quite difficult to take a history because they'd be unstable. So you would ask the same questions as PV bleeding for an APH, and your most likely diagnosis would be endometritis, but like we said, any of the 40s can cause secondary PPH. For your patient in hemorrhagic shock, it would be your A3 approach, making sure that you mentioned that you want your seniors there quickly, so your obstetric seniors, anaesthetists, haematologists, etc., the full MOH crash team. And then you would need to replace the blood products, try and find the diagnosis and the cause for the PPH, and then go through the medical and surgical management in a stepwise way, so it's on the slides. And that's the same for emergency management of PPH as well. So we've got some more questions. So I'll put the poll back up for this question. So the most common cause of PPH. So you should be able to answer that now. Okay, I think most people have voted, so I'll just end that. So yeah, most of you said tone. So tone is the most common cause of PPH. So it's, like we said before, yeah, the most common cause and what we normally assume is the cause if we can't find a cause and what we start treating for. And then the last question, again, I'll set the poll up so that you can answer. So just take a minute to read and then answer via the poll. Okay, I think most of you have voted again. Let's give it one more second. So yeah, so most of you correct. So the first line treatment would be, the first line surgical treatment would be the intrauterine balloon tamponade. That's what you'd want to try first, once you'd exhausted the medical management. So just a quick summary. So APH is bleeding from the genital tract between 24 weeks and birth. The main causes are Placenta Praevia, Vasa Praevia, abruption and genital tract bleeding, or unexplained bleeding that we never find the cause for. So PPH is immediately and up to 12 weeks, so that's primary or secondary, and the main causes are the 4 Ts. And important to remember that you need to follow an A to E approach when assessing either APH or PPH, and keep in mind that this could be a concealed blood loss and it might not represent what you're seeing. Thanks. So I'll just leave the feedback slide up. I'd really appreciate it if you could fill the feedback in, and then I can just quickly see if I can answer some of these questions. So we had a question, what is the problem with vaginal birth and placenta previa? So Placenta Praevia is, as a diagnosis, is when the placenta fully covers the internal cervical os. So if you allowed this lady to go into labour on her own, the baby has to push through the placenta in order to come out. As you might know, labour can go on for quite a long time. With each contraction, the baby's head would be pushing into the placenta. So you're likely to cause basically massive, major life-threatening hemorrhage in doing this. And then the baby's head would need to come through the placenta. So basically you're just putting her at a very, very high risk of hemorrhage and mortality for her and the baby. So I hope that answers that one. The second one, Wharton's jelly. Yeah, so Wharton's jelly is basically a substance that's in the umbilical cord, and it basically protects the fetal vessels inside the umbilical cord, so that it protects them from any trauma, so that they don't bleed, basically. So that's inside the umbilical cord, but it's not surrounding the fetal vessels in Vasa Praevia, so that's why they're at higher risk of rupturing. The third one, how does APH cause IUGR? So it does depend on the cause, basically. It's if you have, say, for example, a small placental abruption, so you might have some of the placentas come away from the uterine wall itself, therefore you're going to get less blood to the baby, so this can restrict the baby's growth. So any problem with the placenta can restrict the baby's growth, as a baby's receiving less blood, oxygen, nutrients than it should be, so it can reduce the growth. So that's how APH can cause intrauterine growth restriction. Can endometriosis cause APH? So endometriosis isn't usually associated, so endometriosis is mostly associated with pain, but it can be associated with vaginal bleeding as well. So you would need to take history from this woman. Endometriosis isn't really going to be a diagnosis you would make during pregnancy. So it would be something that she'd probably have a diagnosis from before. And does she get bleeding with her endometriosis, and is this the same? You would need to ask her that, because you wouldn't really want to assume that this bleeding is coming from her endometriosis. There's a lot of other things that are more likely to be causing APH in that case. So why is digital exam more dangerous than speculum? So when you do a speculum, you're actually not going through the external cervical os. So you open up the speculum, it may come briefly into contact with the cervix, but you're not going through the os itself. When you do a digital vaginal exam, your aim is to assess the cervix, so it's dilatation. So most of the time you'll be putting a finger inside of the external os and through to the internal os potentially. Therefore, you are at higher risk of actually touching the placenta and causing trauma to the placenta and therefore causing bleeding. Whereas in a speculum, this doesn't happen. So speculums are quite safe. You often will do a speculum in a lady with Placenta Praevia. You should have your senior with you if you're doing that. And you can also do TVUS in women with Placenta Praevia, but you wouldn't do a vaginal exam, and you would advise them not to have sexual intercourse just because of the risk of the penis actually causing trauma to the cervix, especially if the cervix is softer if you're coming towards labour. So that's why you can do a speculum and you shouldn't do a vaginal exam. And then how much blood do you need to lose for massive obstetric hemorrhage? This is going to depend on your hospital. And to be completely honest with you, evaluation of how much blood has been lost is really, really inaccurate and really bad. So as humans, we're awful at assessing this. So you can weigh pads and things like that. But realistically, you're going to visually go off of how much blood there is. You're more going to go off mum's symptoms and signs. So if she's becoming tachycardic, hypotensive, etc., and you definitely need to battle the massive hemorrhage critical. But to be honest, there's not a specific amount of blood which would make you put that call out. You just have to kind of go off a case-by-case basis. I hope that covers that one. The next one, filamentous insertion for Vasa Praevia. So you should all be able to get access to these slides afterwards, and I've done a bit more of a explanation of what it is in the notes section below. But basically, normally in a normal pregnancy, your umbilical cord would go from the baby straight into the placenta, and like we were saying before, that whole umbilical cord is protected inside the cord with Wharton's jelly, and therefore the fetal vessels inside of the umbilical cord are protected. If you have filamentous insertion, then basically that doesn't happen, and what happens is the umbilical cord inserts into the amniotic membrane and then becomes just the fetal vessels. So the fetal vessels become not protected by the umbilical cord and Wharton's jelly, and they travel through the amniotic membranes, and then they insert into the placenta. So you have all these fetal vessels just in the amniotic membranes, not protected at all, and that's why they're at a higher risk of bleeding. But you'll get the slides and hopefully that will make a bit more sense. And then the last one, which degree tear do you give antibiotics? So any 3rd degree tear or 4th degree tear, because of the involvement with the anal sphincters or the anorectal mucosa, they're at obviously a higher risk of getting an infection, so you need to give antibiotics for any 3rd or 4th degree tear. So I hope that's covered all of the questions. Thank you very much for everyone for listening. If there's no more questions.
Great, thank you so much for hosting that.
Thank you.
And thank you everyone for attending. And if you haven't yet, please do fill out the feedback form. It's just the link that's posted in the chat. We'll leave that open for a few seconds and then we'll close the webinar.